Okay, our next speaker is a very good friend of mine, Dr. Haouilou, who comes from Venezuela, was born and raised, and where he did his medical school and graduated in 2003, at which point he then traveled to the United States and was accepted and matriculated into his general surgery residency at St. John's Hospital in Detroit. He subsequently went for his vascular surgery fellowship at Connecticut, the University of Connecticut in Hartford, Connecticut. During that time, he was quite involved in some missionary work in Venezuela to help his community, as well as start some programs in treating some of the infectious diseases of those times. He currently serves as Chief of Vascular Surgery at St. John's Medical Center. I know he has an excellent and busy practice there. He's also been well published and is currently won numerous awards, including teaching awards, and as well as Top Doc awards in 2014 and 2015. Today he's going to be talking to us about venous thromboembolic disease and newer anticoagulant therapies, roles of early thrombolysis and mechanical thrombectomy.
Okay. Good evening. We're going to speak today about venous thromboembolic disease. So a step ahead after venous insufficiency, we're going to start the talk tying it up with a previous talk from the clinical standpoint. So these are basically what we're going to go through. The venous insufficiency, we're going to talk about acute and chronic DVT in the lower extremities. We're going to talk about endovascular and open interventions. Pulmonary embolism and what's the current role for any intervention, whether it's open or endovascular. And as I always bring it up every time we're talking about the venous interventions is to talk about upper extremity DVT, in particular about thoracic outlet syndrome, just more for awareness and possible treatments. Tying up from the previous talk, the CF classification, in this particular subset of patients, we're going to go a little further into the more advanced segment, which is severe edema, lipodermatosclerosis, healed ulcers, as well as active ulcers. And this is a simple example of patients with the far advanced end of venous disease. Same thing when we go to etiology in the anatomic segment. We're going to be talking about secondary, which means deep venous thrombosis in the past with recurrent, with residual stenosis or occlusion, and we're going to talk about the deep segment. As far as pathophysiology, deep venous thrombosis can cause both reflux and obstruction, or either one individually, and most of them are symptomatic. So we'll talk, as most of us, we work in a hospital setting, and this is a general surgeon's mandate across the country. Everybody that's in the hospital should be on some sort of DVT prophylaxis, and this is the basis for it. This is from CHEST in 2008. Based on what you're in for in the hospital, your risk of DVT is anywhere between 10 and 80%, which is extremely high compared to the average population that is walking around. Key to this is prevention, and you're going to see on the next slide why we insist so much in prevention. It is a national guideline for DVT prophylaxis. The treatments, even though we have many and we are progressing, they're not as good as never having a DVT. Why is it such a high incidence of DVT in the hospital? Number one, pro-inflammatory factors, which causes a transient hypercoagulable state on every patient that is in the hospital for any disease that they are in. It is higher when a patient goes through a very severe trauma, significantly less when they come in for a flu or a cold. Local trauma and muscle injury, which happens very often, as well as decreased ambulation. And we always compare ourselves to Europe. They have a little less regulation, sometimes they're a little more aggressive on their mandates. And there's a couple of hospitals in Switzerland, which I think is awesome. Patients that are able to ambulate, they do not need to be confined, they get a ticket at lunch for them to go get their own food in the cafeteria. Specifically for this, to increase ambulation, make them walk, get out of the room. In the hospital, everything comes to you. You don't have to walk more than 3 or 4 steps. Everything is next to you. So I think this will be a trend as time goes by. ambulation. So what are we treating once a patient has an acute deep venous thrombosis? Number one is prevention of thrombus extension. 3 times the risk of reflux in these involved segments, and I have a picture later on to explain why this happens. Prevent venous thromboembolism, which is absolutely a life-threatening and life-limiting pulmonary embolism, which is absolutely number one in treatment. Recurrent thrombosis, post-colytic syndrome, it is 6 times higher when a patient gets a secondary or a tertiary DVT, and this is what we're trying to prevent afterwards. And finally, venous insufficiency and venous hypertension, which causes the post-colytic or post-traumatic syndrome, which is leg swelling, skin changes, and ultimately venous ulceration, which affects significantly quality of life. So a little more graphic pictures. When we talk about acute deep venous thrombosis, edema and pain is the number one sign and symptom. They are only limited to the lower segment of this. Once it becomes extensive, then we talk about phlegmasia and ultimately venous gangrene, which can happen. Think about any piping system. If there's no outflow, there's nothing that the inflow can do to keep that tissue alive. And you start having this extensive venous gangrene as you see in these pictures. So why do we perform an intervention on anybody that has an extensive acute deep venous thrombosis? I'm going to define extensive first. Currently, and this is across the nation, iliofemoral DVT should be evaluated for a percutaneous intervention on everybody across the country. Not everybody needs an intervention, but everybody should be evaluated for it. It is a small window of opportunity, and we'll get to that in a second. If a patient does not get treated, 90% will have ambulatory venous hypertension that can be measured. Venous insufficiency, 40% will have venous claudication, and 15% will go on to have a venous ulcer. The quality of life once you develop a venous ulcer is significantly decreased. And the recurrence rate of a venous ulcer is 80% at 2 years without any deep venous intervention. This is an example. This is one of my patients. This is probably a couple years ago from this picture that we have from another slides. You can see on the left side of the picture the inferior vena cava with filling defects within the inferior vena cava in a filter that is completely occluded. So this is complete thrombosis of the iliofemoral system as well as the inferior vena cava with very little flow going through. After a day of treatment, you can see on the next door picture is the same patient. The filter is open and the entire iliac and vena cava system are open. This is a secondary example. Same thing. This is a filter which is called a trapeze filter, which has the highest rate of vena cava thrombosis out of any filter that we can use in the market. It's actually 5 times higher vena cava thrombosis rate than any of the other filters. This is one of those examples, a young patient, inferior vena cava thrombosis with very little flow through after mechanical thrombectomy and lytic therapy. The system is open. The flow is actually so brisk that you can barely opacify the veins from the flow going through. So, what do we do and what are we looking for when we do an intervention to a deep venous system? Number one is thrombus removal for acute deep venous thrombosis. Sometimes it's all acute, sometimes acute and chronic thrombosis makes it a little more difficult to go through the scar tissue. Select the patients with extensive acute proximal DVT, good functional status, low risk of bleeding complication. They are very, very vague on the indications. It all depends on what you feel is necessary based on the clinical symptoms. I'm very pro performing this intervention as long as the patient has a very good functional status and a low bleeding risk. After the thrombus is removed, we remove the underlying, or we fix the underlying lesion, which would be with PTA or stent. I don't believe in performing the intervention to the stenosis if it's a May-Turner syndrome or something similar at the time of the acute DVT. Let the vein heal, the endothelium heals over a few weeks, and the intervention can be done down the road. After thrombolysis, and this is very important, the treatment needs to continue as standard treatment. Everybody should continue to be in anticoagulation for at least 3 to 6 months. If they have more than 2 DVT, then it becomes lifelong anticoagulation. The reason for this is the endothelium in the veins are completely effaced, completely damaged, and the entire surface of the vein is a procoagulant surface. These patients need to be aggressively anticoagulated for at least 3 to 6 months. Some patients, you cannot move from the bed. They are very sick, sometimes with right-sided heart failure due to the DVT or DE. In these patients, always to remember systemic thrombolysis, which usually is 50 or 100 milligrams of TPA as a single bolus, does work. Very high risk of bleeding, but it is a last resort on patients that are very, very sick, and you cannot take them for a catheter-directed thrombolysis. We only have a small window of opportunity. Anybody that has an acute DVT, they should be evaluated within that week to be intervened within the next week. Once 3 weeks go by, it becomes a solid clot, and at that point, it is very difficult to treat or to remove. You cannot melt the clot. The TPA works only for about 3 weeks. Just about 4 weeks, we've had some good results, but no more than that. Yes, now we're going to talk about a few tools that we use for thrombus removal. This is a historical picture. Trellis catheter used to be one of our main devices to use. As you can see on the picture on the left on the x-ray, there are 2 overimposed pictures, a very long segment treatment. We can inflate a balloon above, inflate a balloon below. In the middle segment, think about a jumping rope. It's this oscillating move that morcellates the thrombus, and you can locally inject TPA in that segment. Very, very good success rate. They had some issues with the tip and the catheter itself. The company decided that it was more expensive to fix than to let the company go. So unfortunately, this is a device that there's no longer available. Second device that we use on a very frequent basis is called the ECOS catheter. It's an ultrasonic vibration. The key to this device, when we put it across thrombus, the basis of this is TPA has very little penetration. If you think about a vessel that has full of thrombus and you put a little catheter to lyse TPA, TPA can only penetrate about 1 millimeter. So it'll take a very long period of time to go through the thrombus. What this ultrasonic device does is theoretically creates cracks through the thrombus as you're infusing TPA, so the surface of action of TPA is significantly higher. And we've seen some faster results with ECOS compared to regular infusion catheters. This is the classic infusion catheter. It looks like a garden soaker hose that I'm sure everybody has seen. We put it in the vessel, we infuse TPA, and it pretty much bathes everything in TPA. It has to be given over a few hours. I've seen that about 6 to 8 hours tends to be enough of a treatment. If we do it in the morning, we repeat it at the end of the day. Otherwise, we let it lyse overnight. Sometimes we do a couple of days of treatment, but it is on the seldom side of the interventions that we do. The next one, and I think this has been a great device. This is, it's called Angiojet. The easiest way to describe it is an internal power wash. It pushes water at a very, very fast rate. If you actually hold it in front of you, the water will go about 2 or 3 feet away from how much pressure there is. And at the same time, it's aspirating with a smaller hole just ahead of it. It causes this turbulent flow that morcellates the thrombus. You can inject TPA and force it into the clot, and you can release. You have a little faster resolution within a segment that you can treat. It is limited because it causes severe hemolysis up to the point that can cause renal failure from it. So you are limited on the amount of time and how much you can use this device. You get it against the thrombus, and slowly you can suck most of the thrombus out of the vessel. It has very, very good results. I use it mainly in patients that cannot be anticoagulated. So post-surgical patients, whether it's from large tumor resections or post-pregnancy delivery C-section, we tend to use this device a little more often. Almost historical open interventions to bypass the occluded segment. Very, very rare that we get to do these. We've done a few recently due to trauma in younger patients, but extremely rare that we get to do these open interventions anymore. So, does it work? Other than looking at a picture and say, yeah, we have immediate result, it looks great, do we have any data on this? And yes, the data is growing extremely fast, not just across the country, but across, especially in Europe, the data is impressive. So, this is a multi-center randomized trial from Sweden. demonstrated that patients undergoing venous thrombectomy versus patients receiving anticoagulation alone, they had improved iliac vein patency, lower venous pressures in the lower extremities, less edema, and fewer post-thrombotic syndromes. What happens when the acute DVT goes to chronic DVT? And this is the reason why the vessels get damaged and you get this post-phlebitic syndrome. So what ends up happening is this is the picture of a valve inside of a vein. Flow is going, as you can see, the arrows on the white is left to right. The blood flow is it is inside of the white arrows. That means the actual cul-de-sac or the base of the valves, it's stagnant flow no matter what we do. It is very tough to get the thrombus out of this, which means the valves become incompetent because they get solidly fused to the sidewalls. Once the valves are not functioning, then you have an insufficient vein. The way I describe it to my patients is, think about this big long straw full of water and you take your finger out of it. All the water is just going to pool all the way down. That's the constant pressure of an insufficient vein at your feet, and this is what causes swelling, damage to the skin, which is this browny skin that causes an ulcer or lipodermatosclerosis. This is what happens when you go from an acute to a chronic deep venous thrombosis. The upper graphic is a vessel that is completely occluded and it regresses to be a small vein that doesn't have any flow through it and is completely occluded. The bottom one is when you have partial recanalization, but it always becomes a smaller, thicker vessel. It doesn't function as well as originally was, and it doesn't take as much flow through. And the other example that I use is trying to drain the flow of a rain shower through a straw. There's not enough and everything is just going to accumulate. This is how it looks in anatomic pathology. This is called venous synechia, which is a scar tissue that forms in the veins after an acute DVT. These are examples of prior patients that we've had. As you can see on the left picture, all you can see is this collateral vessels. Remember, this is a 2D view of a 3D world, and these collateral vessels that you're seeing are collaterals that are going down through the gluteus, down through the pelvis to come back into the deeper circulation further north or closer to the heart. Once we reconstruct it, then the collaterals become significantly decompressed, which is what the goal of what we're seeing. The flow is going directly into the vena cava rather than through the collaterals. Done? Can I bother to see if the video plays? As you can see here, this is a patient with a chronic occlusion of the right iliac venous system. And this is a cross-pelvic varicose vein collateral, which is really what's draining the entire leg all the way to the other side to be able to drain the entire system. Final topic, pulmonary embolism. Why do we consider an intervention? So a pulmonary emboli large enough to cause right ventricular dysfunction are associated with a 6-fold increase in hospital mortality and a 2-point-fold increase in a 1-year mortality. This is an example of one of our patients just a few months ago, big abdominal surgery with heat and intraperitoneal chemotherapy, large pulmonary embolism afterwards, was on high flow, oxygen in the room, and this is what we're looking for: symptomatic, acceptable breathing risk, life-limiting, life-threatening, or right heart strain. This is the intervention. We used Angiojet. We didn't do lytic overnight due to the previous surgery, and the results were excellent. The patient was walking on the hallway across the hall for minutes at a time compared to where he was before. So something to consider. Again, the indication as we speak is very, very vague. Nothing that's set in stone, but everybody should be evaluated for a possible minimally invasive intervention for a pulmonary embolism. Finally, and this is just a little topic for awareness, even though it is very, very rare, if it gets picked up on time, the treatment is significant, is very successful. Upper extremity deep venous thrombosis, young patients, unprovoked, non-line related, and possible exercise related. Always think about effort vein thrombosis or Daggett-Schroeder syndrome from thoracic outlet syndrome. This is how it looks on an acute, the acute thrombus on the left side, and has the occlusion on the right side. To have a better visual picture, this is after treatment. We can see a little stenosis, and this is probably the best picture I've been able to get to show how it works. If you see the clavicle and the first rib that's right underneath it, The patient, if you follow the vessels, is going up. The arm is all the way abducted. Severe compression of the vein, which happens on a repetitive basis, which causes a local occlusion. This can be treated by a local resection of the first rib, plus or minus reconstruction of the subclavian vein all the way to the innominate vein. And this is how it looked post-operatively with a few sternal wires after we resect the first rib and repair the veins. Finally, the key to a good long-term success in venous disease, whether it's acute or chronic, it's correct and prompt diagnosis, complete evaluation, access to current treatment options, and without a doubt, regular follow-up for possible needs of future interventions. Thank you.
Thank you, Jimmy. That was great. Do we have any questions for Dr. Haouilou? Yes.
Do you do your own wound care, or do you put patients on for
I do. We have a large wound care in hyperbaric, and I'm the medical director of the clinic. So we have a very busy place where we have a bed.
Do they still do greenfield filters, or those gone by the wayside?
We do. I don't think that they'll ever go by the wayside. I think that there's always a role for a greenfield filter. I think everybody should get a retrievable IVC filter for two reasons. One, if it misdeploys, you can take it out and redeploy it. Number two, they can have issues down the road, and most of the patients, their high-risk period of DVT or PE is gone within a month or two, and the filter can be removed safely within 6 to 9 months.
Jimmy, one of the things I get called about quite often is DVTs, and not only that is that common in the inpatient population, but as well as the emergency room. And I think your talk really highlights the importance of early intervention in patients with DVTs, aggressive treatment and aggressive intervention. I think gone are the days of just anticoagulating and compression stockings and kind of waiting and seeing how things go. Lytic therapy, aggressive angiojet or ecos, etc. These therapies not only preserve valve function to prevent post-thrombotic syndrome, as it is a very disabling condition. These patients are older, they get swollen legs, and the only treatment is compression stockings. And so that dogma of just if somebody has a DVT, we'll just anticoagulate, that's not really the mainstay today. It is aggressive intervention, and it's something that we try to talk to our ER doctors to really understand, and I think they've got it. And hence I get called all the time for DVTs, and we intervene on them early. And so questions for you is that for those particular patients that do have DVTs, how do you determine, this is a patient that I do want to aggressively intervene on, or this is a patient that I may not want to? What's your algorithm that you use?
So, very simple. Number one, if they have a good functional status, they're out there walking, they're moving around. And number two, they're symptomatic. Most of the patients will have some sort of leg edema, leg pain, and the part to take into context, most of these patients, they've been laying in bed for a few days. So if they have edema while they're laying in bed, once they get up and walk and go into daily activities, it is going to multiply because now you have gravity into it. And anybody that has anything higher than a popliteal DVT, if it's the femoral vein through the thigh, deep femoral, common femoral, or iliac, definitely should be intervened. Yes?
Do you put a filter above the thrombus?
Used to. A few years ago, when we started doing a few more of these and getting a protocol and being a little more aggressive into it, that was the thinking. We put a filter on everybody, we took a filter at the end of it. As we speak, I don't. The embolization rate of these have been minimal. And the only time that I do it is when I'm treating a PE, that the patients will not tolerate a second PE or anything else. As far as a right-sided heart strain and oxygenation, those patients do get double treatment or double protection. But other than that, I don't do it on a regular basis.
Yeah, it is. I have the same dogma. I do put IVC filters temporarily in a lot of patients that I do lytic therapy on. It is a little unnerving watching their sats go down and them getting tachycardic when you do these procedures. So I opt to put them in and take them out after a week. Now, in terms of retrievable filters, obviously We want to take those filters out expeditiously. A lot of patients are worried about filters. You see all these television commercials with lawyers who want to sue for one thing or another. Filters are generally very safe, but you do want to remove them usually within 3 months or so. So greenfield filters are not really one that we offer nowadays. Okay, very good. Any other questions? Yes.
I have a question about the distal venous thrombosis when there is contraindication to use anticoagulation. I'll tell you a personal story from 2 patients within a week. One of them with glioblastoma multiforme, the other one has GI bleed with extensive workup, including capsular endoscopy with no source of infection.
Okay.
So is there a role for the vascular surgeon to intervene? When you talk to IR, I think the distal DVT below knee is not an indication for a IVC filter placement. So now, from medical legal and medical reason, is there a role for the vascular surgery intervention?
So that's a great question. This is something that we deal with on a regular basis. If you have a popliteal or below popliteal, so tibial DVT on a patient, do we anticoagulate or do we put a filter on these patients that you cannot? I base it on the patient. If the patient is ambulatory, very active, calf muscles are working very well, then I don't anticoagulate them and I don't put a filter in. But as long as I can follow up and actually do an ultrasound every week for 2 weeks and then an ultrasound every 2 weeks up to the 2-month mark. Reported rates is tibial DVT on its own, there's a 90 to 100% resolution within the first 6 months. If the patient has a calf muscle injury, foot surgery, they cannot move well, they're an immobilizer, they're in bed most of the time, they're very weak, then you have to assume that they're stagnant flow-wise through the legs, and these patients should require a filter, and I do put a filter on these patients. The reason for it is they will not be reliable enough to follow up with ultrasounds, and there is the reported rate about 5 to 10% extension of the thrombus when it's tibial to above, when the risk factors are still present. Once it extends, then you become to 30 to 40% of PE.
One quick question. The aggressive recommendation to management of deep vein thrombosis, it sounds to me to be new. Do you know whether this is going to be part of the recommendation, especially when the ACCP PE management is updated? Because if you go back to 2008, which is the most recent that we have, there is no recommendation for that level of aggression. You know, it's just going to be anticoagulation. Unless the patient has maybe massive PE, then you can do something.
Unfortunately, the main guideline across the world is the ACCP, which is the American College of Chest Physicians guidelines. They come out every 4 years. In every 4 years, they've been changing significantly. And unfortunately, they have been behind the current treatment. So following ACCP, you are, unfortunately, in venous disease, just a couple steps behind of where everybody else is doing. So yes, you will continue to see changes into more intervention.